Welcome to the fifth English webinar of International League Against Epilepsy, East Mediterranean region. Today, we have the honor and the privilege of having two eminent speakers, Professor Boulenouar Mesraoua and Dr. Maher Arabi. Professor Mesraoua will present the first session and will talk about juvenile myoclonic epilepsy. Then the second session will follow with Dr. Arabi, who will talk about progressive myoclonic epilepsy. As usual, after each session, the speakers will answer your question. Before starting the first session, I would like to introduce Professor Boulenouar Mesraoua. He is consultant neurologist at Hamad Medical Corporation and Associate Professor of Clinical Neurology at Weill Cornell Medical College in Qatar. Professor Mesraoua is actually Director of the Neurology Fellowship Program at Hamad General Hospital, Doha, and also a member of the Comprehensive Epilepsy Program at the same institution. He's also Assistant Director of the Residency Program at Qatar Medical School. Professor Mesraoua is an active and elected member of the Commission of Eastern Mediterranean Region, a member of American Academy of Neurology, the European Academy of Neurology, and the American Epilepsy Society. Professor Mesraoua is the author and the co-author of more than 60 peer-reviewed publications and 5 book chapters in the field of epilepsy and clinical neurology. You have the floor, Professor Mesraoua.
Good evening, and thank you for the invitation. So I will talk today about juvenile myoclonic epilepsy, a very interesting epilepsy syndrome. I have no conflict of interest. Juvenile myoclonic epilepsy has been recognized by early distinguished physicians. Theodore Erpin in 1867, Robot in 1899, but it was not until 1957 when Jans and Christian first described GME in 47 German patients. Since then, it was reported from everywhere. The International League Against Epilepsy Commission defined GME as a distinct syndrome of idiopathic generalized epilepsy. The syndrome appears around puberty. It's characterized by seizure with bilateral, single or repetitive arrhythmic irregular myoclonic jerk, predominantly involving the arms. Jerk may cause some patient to fall suddenly. Disturbance of consciousness is not very noticeable. The disorder may be inherited. There is a female preponderance. The absence seizures are infrequent. The generalized tonic-clonic seizure very frequent. The seizures occur shortly after awakening. Often they are precipitated by sleep deprivation. Interictal and ictal EEG show rapid, generalized, often irregular spike and wave, and characteristically polyspike and wave discharge. Frequently, patients with the GME show photosensitivity, and the response to anti-seizure medication is generally good. What about the incidence, prevalence, and sex ratio of juvenile myoclonic epilepsy? As you know, GME is most common form of genetic generalized epilepsy. The occurrence is very high in the MENA region, Middle East and North Africa, and reach 82%, comparing to its occurrence in the US, 40%, Mexico, 20%, and Central America, 8%. The incidence of GME varies from 0.5 to 6 per 100,000. And based on 1% of population risk for epilepsy by the age 20, the risk of GME in the general population would be 1 per 1,000 to 1 per 2,000. The prevalence of GME is estimated to be 5 to 10% of all epilepsy and almost 20% of idiopathic generalized epilepsy. There is, as you know, a marked female predominance in GME. Juvenile myoclonic epilepsy has an age-related onset. Seizures appear between 8 and 26 years with a mean age of onset around 14, 15 years. However, the majority of seizures occur between 12 and 18 years. The absence seizures in GME are reported in 1/3 to 2/3 of GME patients. The myoclonic jerk in almost all patients, and the generalized tonic-clonic seizure in around 80% of patients. Early or later stage of onset has also been reported, and we do have patients with GME starting their first seizure during the 3rd decade, and at least one patient during the 4th decade. Early onset of juvenile myoclonic epilepsy in female patients with photosensitivity. This slide, which was reported by Jans, who first described the GME in German patients, show an age of onset peak around 14 to 15 years. The myoclonic jerks are the most important aspect of the clinical presentation of GME. Myoclonic jerks occur prominently and spontaneously in the morning after awakening. They are sudden, short-lasting, irregular, frequently symmetric, but they can be asymmetric. They may be self-limited or may occur in cluster. If prolonged, cluster may lead to a convulsive tonic-clonic seizure. Myoclonic jerk involve prominently the upper limbs. However, the lower limbs and trunk are not often spared, even the face. Both distal and proximal jerk movement do occur. During myoclonic jerk, patient may throw things out of their hands, a cup of coffee, for example. Myoclonic jerk may be so intense that patient fall to the ground. This is called myoclonic astatic seizure. There is some degree of asymmetry in myoclonic jerk, as well as some focal feature on the EEG, which we'll discuss later. Myoclonic status epilepticus is not rare in GME. The main cause are drug withdrawal, sleep deprivation, and alcohol intake. The generalized tonic-clonic seizure often occur upon awakening, and often family report generalized tonic-clonic seizure after repeated myoclonic jerk. The absence seizure, 1/3 of patients with GME to 2/3 of patients. They are mild, short, when compared to childhood absence epilepsy and juvenile absence epilepsy. They are often unnoticed. Martinez-Juarez describe 4 groups of GME. The classic GME, around 70%. Second, the childhood absence epilepsy evolving to GME, around 20%. GME with adolescent absence, 7%, and GME with astatic seizure. This video shows a patient with GME, a young lady. Please listen to her carefully. She will describe most of the symptoms and of GME, and also watch the video. The patient will present few myoclonic jerks, involving sometimes the face, as well as an absence seizure.
Just woke up from a nap and it's never good timing for myoclonic seizures, especially when it's 4:03 in the afternoon. I took a nap for a few hours and I woke up like 10 minutes ago. Well, maybe long, maybe like 20 minutes ago. And like I started having my jerks and 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 basically this is what happens during myoclonic seizures. I usually never catch them on camera because they usually happen in the morning. In the morning, I'm tired and all I want to do is eat breakfast and get dressed and get ready with my day. But it's really not that bad. I mean, now that I'm on Keppra, it's not too bad. As it was, I was dropping things, throwing things before. Now, like, I don't really get them anymore, or unless I just don't notice them at all, which if I don't notice them, that's great, but I'm noticing them now for some reason. I don't know. Yeah, so this is what they look like. Nothing special. I think they look Tourette's. That's just me. no hate here on Tourette's. My cousin has Tourette's, so no harm, no foul. My cousin and I, we actually are BFFs, so we both tease each other because he doesn't really jerk like I do. He does like this weird flapping thing with his arms. I don't know how to explain it, but yeah. So can't wait until fall semester when I fall asleep in class. Better up that Kepra.
Of myoclonic jerk early in the morning. What about the precipitation of seizure in juvenile myoclonic epilepsy? The occurrence of myoclonic jerk early in the morning are the hallmark of GME. Myoclonic jerk and generalized tonic-clonic seizure are induced, as you know, by sleep deprivation, fatigue, and excessive alcohol intake. There are also other seizure-provoking factors like stress, fever, sleep, flashing light, music, reading, and thinking. The photosensitivity in GME, which is a paroxysmal EEG response, is age-related and vary considerably. Absence seizure is induced by photic stimulation, by hyperventilation. Myoclonic jerk are provoked by cognitive tasks. Electroencephalography of GME. GME is widely under diagnosed despite a characteristic clinical picture and a distinct EEG profile. Patients with clinical suspicion of juvenile myoclonic epilepsy and a normal EEG should have a sleep EEG or an EEG or awakening. Background activity is usually normal. There is some theta slowing during poor seizure control and an increase in absolute power of delta, alpha, and beta band in the anterior region. The interictal EEG show diffuse or generalized spike and wave, and characteristically, polyspike and wave discharge at 3.5 to 6 Hz. There are also localized EEG abnormality. In 1/3 of cases, there are fragmented generalized spike and wave, focal or multifocal. They may be also unilateral discharge with unilateral onset and also discharge with above 50% voltage asymmetry at sleep onset or after provoked awakening. The photosensitivity is variable and can reach 90%. Photic stimulation is frequent in female and adolescent. This slide represents a typical EEG, interictal EEG, in a patient with juvenile myoclonic epilepsy. The background activity, the alpha activity, is normal, posterior at 9-10 CPS. And look at the generalized polyspike and wave discharge predominantly in the anterior leads. These a burst lasting around 2.5 seconds. This is another EEG in a 20-year-old female patient during photic stimulation. This is what is called a photoparoxysmal response, during which the patient is presenting some jerky movement of both upper extremity. Look at the predominantly anterior spike and wave discharge running faster than 3 per second. This EEG was obtained in the same patient as previously. This is during hyperventilation, and it shows characteristic generalized polyspike and wave complex, predominantly anterior, and accompanied by mild impairment of cognition. What about ictal EEG? During myoclonic jerk, the EEG shows generalized burst of multiple spike of short duration, frequently followed by slow wave with poorly structured spike and wave sequence. During generalized tonic-clonic seizure, we can see generalized fast rhythmic spike in tonic stage. During absence seizure, there are frequently regular fast, 3.5 to 6 Hz, generalized spike and wave or polyspike and wave discharge. This EEG is obtained in a patient with GME. Look at the normal background activity posterior and the brief generalized polyspike and wave, always predominantly anterior.
So, sorry for this technical problem. The focal, as I said in the beginning, the focal abnormality are not rare in juvenile myoclonic epilepsy. Can you, Shannon, can you get me the previous slide? Previous one. Yeah. Are the focal EEG feature are not rare in juvenile myoclonic epilepsy. This slide shows on the left side all focal abnormality, including focal slowing and EEG abnormality, and on the right side the focal epileptiform abnormality. So you can notice that on the left side, in some study which are represented by color. Can we go to previous slide? Yes, this one. Stop there. Yeah, in some study like the blue one, the percentage of patient is more than 50%. With focal EEG abnormality. On the right side, the focal epileptiform abnormality might represent present in 1/3 of the patient. Okay, next slide, please. Next slide. Yeah, this one, yeah. Okay. This also describe the focal clinical abnormality in patient with juvenile myoclonic epilepsy and in general, and generally in idiopathic or genetic generalized epilepsy. This slide compare the patient with a temporal lobe epilepsy in orange color and the patient with idiopathic generalized epilepsy in blue. As you can see, the focal chronic or tonic seizure occur in 2/3 of the patient with juvenile myoclonic epilepsy and primary generalized epilepsy. The versive seizure, again, the same, they occur in 2/3 of the patient, and the asymmetric or asynchronous chronic phase occur almost in 1/3 of patients with idiopathic generalized epilepsy or genetic epilepsy. Next slide, please. Now the previous one, yes, stop here. Okay, this is an anterectal burst of generalized polyspike end wave in a patient with GME. On the left side, it's synchronous. There is no leading point on the left side in A. However, there is a clear leading point in the middle in B, on the right side. On the right side, there is a clear leading point on the left side. Next slide, please. Okay. What about genetic of juvenile myoclonic epilepsy? GME is the most common cause of hereditary seizure in people with epilepsy in the population at large. In GME, there are both Mendelian inheritance and complex genetic inheritance. 49% of GME family have clinical EEG traits suggestive autosomal dominant inherited disease. The variant of GME gene with small to modest effect contributes to the risk susceptibility in the remaining 51%. Next slide, please. Previous one. Yes, here. So, about take-home message about genetic of GME, the pattern of inheritance is complex, polygenic, or Mendelian. The known genes are here, 7 of them. There are also microdeletion, such as the 15q13.3 microdeletion, and the other also microdeletion, which have also been associated with juvenile myoclonic epilepsy phenotype. The family history is interesting also. A positive family history of epilepsy is occasionally present, typically of GME or other genetic generalized epilepsy. Next slide, please. The neuropsychological findings and behavioral study in GME are also very interesting. Already, Jans in 1957 described a personality trait in GME patient with a social immaturity, lack of ambition, and lack of endurance. The Valente found an altered performance in neurocognitive function, psychological dysfunction involving almost 75% of patients with GME. There is also a deficit in attention, planning, and verbal fluency, as reported by Walsh, and myoclonic jerk are precipitated by complex cognitive guided motor tasks, as reported by Garana. There is also predominance, and it's well known, predominance of anxiety, depression, and mood disorder in a patient with GME. GME patients are emotionally unstable with a greater propensity to show impulsive disorder. When compared to patients with frontal lobe epilepsy and mesial temporal lobe epilepsy, GME patients show similar level of impairment in recognition of negative emotion. Next slide, please. Hello, yes. Are regarding the neuropsychological and behavioral, are these genetically determined or are the a consequence of social life relationship difficulty produced by seizure activity? The impairment, these impairments are frequently seen in treatment refractory seizure, GME, of course, compared to those with effective seizure control. And in GME and sibling also, there is a deficit in memory assessment as shown by Iqbal. In summary, GME patient and clinically unaffected sibling present an irritable trait that manifests in individual whether the condition being GME is active or not. This trait is found more frequently in GME non-affected family member than in the general population. Next slide, please. The neuroimaging in GME also are very interesting. The brain abnormality are not rare. There is a volume reduction of hippocampus with incomplete uni or bilateral hippocampal inversion, what is called hippocampal rotation in 50% of GME patients and their unaffected sibling. You have to know that hippocampal malrotation is not an etiologic factor for epilepsy, but is an in utero process, which could be a sign of disturbed cerebral development leading to epilepsy. Thank you. Next slide. Yeah. There is also an increase in mesofrontal gray matter thickening with abnormal cortical organization in GME, as shown by Warman. There is also widespread cortical thinning in temporal, parietal, and occipital lobe in GME, and also a decrease in volume of the thalamus and putamen, as shown by Kim and Keller. Yeah, next slide. The functional MRI also has shown change in functional and structural connectivity between supplementary motor area and motor cortex during working memory task in GME, as shown by Volmar. It's well known that precipitation of myoclonic jerk by cognitive task is a feature in some patients with GME. Next slide, please. The question comes up and is, are these neuroimaging abnormality, neuropsychological impulsivity, and the executive dysfunction in GME the result from development variation or the consequence of chronic seizure and anti-seizure medication? To answer this question, GME patients were evaluated within their first year of epilepsy. Pulsifer found a smaller thalamic volume, more frontal CSF and executive dysfunction detected in GME children, but not in benign childhood epilepsy with central temporal spike. El-Meki found a white matter abnormality in many structures, prefrontal part of the frontal cortex, thalamus, corpus callosum, in a new onset GME. In conclusion, is the reduced gray matter volume in thalamus and white matter abnormality are not the effect of chronic seizure or anti-seizure drug, but an in utero process. Next slide, please. What about the management of GME? According to the International League Against Epilepsy, in GME, the response to appropriated drug is good, which is true. However, 15% of patients with GME might be drug resistant. Today, with the available 30 anti-seizure drug, among them many are new, the rate of drug resistance might be lower. Of course, the choice of anti-seizure drug is based on clinical experience and available study and trial. Several anti-seizure drugs can be used with success in patients with juvenile myoclonic epilepsy. However, some anti-seizure drugs can aggravate myoclonic jerk. Next one, please. As you know, valproate is still the first-line treatment in GME in male and female without childbearing potential. The dosage in adult vary from 500 milligram a day, which means 250 milligram BID, to 2,000 milligram a day. The control rate reach up to 90% in different studies. Lamotrigine also is used in younger women because of potential teratogenicity of valproate. However, lamotrigine is less effective than valproate and has the potential to exacerbate seizure in idiopathic generalized epilepsy and, of course, juvenile myoclonic epilepsy, and can aggravate myoclonic jerk or generalized tonic-clonic seizure with the novel appearance of myoclonic jerk, as shown by Crespel. Topiramate also is, if tolerated, is useful in GME, particularly in overweight patient and associated migraine and in a patient with bipolar depression. But levetiracetam, which I prefer, is highly effective in GME. The responder rate is 60% with 20% of them seizure-free. Levetiracetam, I think, should be one of the options in the treatment of GME as first line or add-on, particularly in women with childbearing potential. However, levetiracetam also might exaggerate Myoclonus. Next one, please. A new drug is very interesting. Zonisamide has a good efficacy in GME. In one study, 80% responder in the monotherapy group with only zonisamide, with 70% of patients generalized tonic-clonic seizure-free, 60% seizure-free for myoclonic seizure, and 40% almost free of from absence. The daily dose was 200 milligram and 500 milligram. Clonazepam alone or in association with acetazolamide is effective in controlling myoclonic jerk and also particularly if absence and myoclonus are associated. Clonazepam can also be combined with lamotrigine in GME to avoid the myoclonic effect of lamotrigine. Lacosamide may be effective in GME. However, there are no larger controlled study, according to the American Academy of Neurology, to start this drug in juvenile myoclonic epilepsy. Next one, please. No, previous one. Previous. Yes, thank you. No, next one. Yes, of course, as you know, carbamazepine, oxcarbazepine, and phenytoin can exacerbate absence and myoclonus and induce status epilepticus. Should not be used in GME. The following anti-seizure drug should not be used in GME, particularly gabapentin, pregabalin, tiagabine, and vigabatrin. They can worsen seizure, particularly diagabine, and vigabatrin might induce absence status epilepticus. Next slide, please. Can we discontinue anti-seizure drug in juvenile myoclonic epilepsy? Yes. The Gaitner followed up 31 patients with GME over 25 years. 21 patients, almost 70%, became seizure-free, and in 6, almost 30%, anti-seizure drugs were discontinued with no more seizure. The most important factor that increased the chance of complete seizure freedom after anti-seizure drug discontinuation is a complete remission of the generalized tonic-clonic seizure under a single anti-seizure drug. The occurrence of a photoparoxysmal response increased the risk of seizure recurrence after stopping anti-seizure drug. Conclusion, lifelong anti-seizure drug treatment is not necessarily required by all patients with GME. Next slide, please. What about the other treatment and approach in juvenile myoclonic epilepsy? Of course, dietary therapy in juvenile myoclonic epilepsy, like Atkins diet, can be useful therapy for patients with anti-seizure resistant juvenile myoclonic epilepsy. Vagal nerve stimulation play same role with an adjunctive VNS therapy is a favorable treatment option for drug-resistant GME. Of course, we should not forget above to take care and treat psychiatric disorder in a patient with juvenile myoclonic epilepsy, and there are numerous, since there are high prevalence of psychiatric disorder in patients with GME, such as mood, anxiety, and personality disorder. So their early recognition and the treatment play an important role in GME prognosis. Last slide, please. Thank you. In conclusion, in GME, there is evidence point to an alteration of brain development when cell division driven by pathogenic variant of diverse GME gene make sculpture subtle alteration in brain network microcircuit structure and dynamic that in turn subserve the psychosocial, cognitive, and seizure phenotype of juvenile myoclonic epilepsy. GME is a common form of IgE with characteristic clinical and EEG profile. Sleep EEG or an EEG on awakening confirm the diagnosis. Despite this clinical and EEG trait, GME is often not recognized as such. This might result in serious consequences for the sufferer. With the correct diagnosis and appropriate anti-seizure treatment drugs, like valproate, levetiracetam, zonisamide, lamotrigine, an important small group of patients will come off medication. Potentially aggravating anti-seizure drug are carbamazepine, oxcarbamazepine, phenytoin, gabapentin, pregabalin, tiagabine, and vigabatrin. They can worsen seizure, and in particular, tiagabine and vigabatrin might induce absence status epilepticus. Thank you very much for your attention, and sorry for the technical trouble. Thank you.
Thank you, Professor Mesraoua, for this precise and exhaustive talk. We are waiting for questions. Before, I would like to make some comments. First, in our countries, in our region, we saw the patient that didn't report myoclonic. It's the incidence is very high, and often they come for generalized seizure. Another thing, as you said, in many cases, there are focal abnormalities in EEG, and sometimes the myoclonic are very partial and unilateral, and the patients receive drugs like carbamazepine or oxcarbamazepine. And as you said, it's aggravates the seizure, and we see this patient in surgical evaluation. This is why it's important to look for myoclonic and an absence, etc. We have some questions. The first question, few juvenile myoclonic epilepsy cases responded very well to carbamazepine. Do you think this worth searching for unifocal lesion despite no consistent focality in EEG long-term monitoring?
Okay. I think, yeah, I can answer this question, yes. I think, yeah, there are cases described of juvenile myoclonic epilepsy which respond to carbamazepine. Yes, that's right. There are exceptional cases, yes, but the carbamazepine can aggravate the juvenile myoclonic epilepsy. But there are cases which treated with carbamazepine, and the patient got in good control. Yes, this is described, well known.
I think also the aggravation changed the symptom, and we are facing complex partial seizure. This is why it's important to make a good diagnosis.
Yeah, I agree. Yeah, you as you said, yeah, almost 2/3 of patients with juvenile myoclonic epilepsy show either focal clinical abnormality or myoclonic jerk or focal EEG abnormality. Yes.
Second question: do you advise patients with juvenile myoclonic epilepsy avoid all computers, program, and driving?
No, there is a high incidence of photic stimulation, but mostly in female. Yes, they can be a little bit far from the computer. Yeah, but the photic stimulation has some effect on. But not to avoid, you know. When you use the computer, you should be a little bit far from the computer, with not in a dark room. Okay. Not in a dark room. Yeah.
What is your experience of using Perron panel in juvenile myoclonic epilepsy?
I did not use, but some report that, but it's not like for example, valproate or levetiracetam. There are some report of some success with Perron panel, yes, but I did not use it in GME. I practically use valproate in ladies. Levetiracetam, it works very well. Lamotrigine sometimes.
Okay. Another question: treatment for long life or not?
No, if the patient is well controlled, if you know his history very well, if he responded quickly in the beginning with one drug and no more generalized tonic and no more myoclonic jerk, you can try to withdraw his medication. Yes. After some years, I mean 10 to 15 years, of course.
A question from our friend Raib. I did not note a motion for lifestyle effect on control.
What is the question exactly about lifestyle?
Yes, lifestyle.
Yeah, lifestyle is very important. The patient should sleep early, avoid alcohol, etc. All this lifestyle that not get very nervous and so, yeah.
And Adil asked, what about Perron panel therapy in juvenile myoclonic epilepsy? I think.
Yeah, this is a repeated question. Yeah, I think Perron panel has some success in, and particularly is very good for progressive myoclonic epilepsy. It's very nice, Perron panel. But there are also some reports of Perron panel in juvenile myoclonic epilepsy. But personally, I did not try it.
Okay, and the last question: can we exclude juvenile myoclonic epilepsy if no myoclonic component in patient semiology?
It's very difficult. It's very difficult to exclude. First, the myoclonic jerk in juvenile myoclonic epilepsy occur in almost all patients. all patients, 97 to 100%. So you cannot have juvenile myoclonic epilepsy without this myoclonic gel, unless it is really typical. The generalized tonic-clonic seizure occur in the morning, and then the EEG is characteristic with the police spike and wave discharge, predominantly anterior. There are some bursts and there are some focal failure, but this is a strict minimum, small group, very small.
Okay, thank you very much, Professor Mesraoua. And now we will move to the second session. We are waiting for our friend Adil Misk. Before that we can start, and I would like to introduce Dr. Maher Arabi. He's currently the director of the Comprehensive Epilepsy Program at Ibn Sina Hospital and is the vice president of the Kuwait League Against Epilepsy. After completing his internal medicine residency at Maqasid Hospital in Lebanon, he joined the American University of Beirut Medical Center, where he completed a 3-year residency of neurology, followed by 2 years fellowship in epilepsy under the mentorship of Professor Ahmed Bidou. During this period, he actively participated in the ongoing new onset epilepsy in Lebanon trial. Subsequently, Dr. Arabi joined Ibn Sina Hospital in August 2012, where he established the first epilepsy monitoring unit in Kuwait. Dr. Arabi has been a regular speaker in many epilepsy meetings across the region and has several publications in peer-reviewed journals. You have the floor, Dr. Maher.
Good evening. I would like to thank the organizers of this series of webinars for inviting me to give this talk about progressive myoclonus epilepsies. The progressive myoclonus epilepsies are a group of heterogeneous disorders that have in common that they are progressive, so they tend to be worse with time and generally fatal. All of the patients have myoclonus, which tend also to worsen with time, and the myoclonus is cortical. And all of the patients have epilepsies. Most of the patients have convulsive seizures. However, they might have other types of seizures, including the focal seizures. And as the disorder progresses, the patients will have status epilepticus. I will try to cover the different disorders through clinical cases. And those cases I have personally evaluated in the epilepsy clinic at Ibn Sina Hospital. So the first case is a 16-year-old right-handed female patient that started to develop seizures at the age of 10 years. Her first seizures were generalized tonic-clonic seizures that were provoked by watching TV. Also, the family noted that the patient started to develop infrequent myoclonus that became very frequent and debilitating 2 years prior to presentation. The myoclonus was triggered by walking during sunny days, and also when she was in the car at night looking at lights or looking at the police lights. So she would have the myoclonus. Also, the patient reported having episodes of seeing colors over the entire visual field, and those spells were also associated with eye pain. Also, the family noted that the patient started to regress intellectually. Uh, Now, her neuro exam showed slow reaction time. She had dysarthric speech. She had the brisk reflexes, a wide base gait with appendicular ataxia, and she had very frequent myoclonic jerks at rest, as well as startle myoclonus. The patient had no family history of epilepsy. However, her parents were first cousins and she had normal developmental history. At the time of evaluation, she was maintained on two anti-epileptic medications, levetiracetam and valproate. Her metabolic workup was negative, and her MRI showed evidence of mild diffuse atrophy. Now I'll go through her EEG. So this is the patient's EEG. We are looking here at a longitudinal bipolar montage with the left temporal derivations followed by the left parasagittal, the midline, then the right parasagittal and the right temporal derivations. From the first epoch, we can appreciate that the patient had a slow background with a background of 7 to 8 hertz. And then here we see those generalized discharges with a bi-occipital predominance. So those were end of chain. So those were generalized discharges with a maximum over the occipital head regions, as we can see here on the average montage. Also, as we go through, we can appreciate as well some focal spikes seen over the left parietal as well as the right parietal head region. And then again, we can appreciate the generalized discharges. Those were polyspikes with a bi-occipital predominance. Now, let me show you her myoclonus. So here the patient is sitting in bed, and we can see that she had sudden jerks involving both upper extremities as well as her torso. Again, while talking on the phone, she had the myoclonic jerks involving both upper extremities. Sometimes the myoclonic jerks were slightly asymmetrical. And again, here we can see, we can appreciate the myoclonic jerks involving the right upper extremity. And all of these jerks were associated with high amplitude generalized polyspikes with a bi-occipital predominance. Now, while doing the photic stimulation with the Z1 lenses on, the patient had the crescendo myoclonus. So the technician stopped the photic, and then the patient appeared to be in discomfort. She started looking to the left side as if trying to hide what she was seeing. And then she had some also left horizontal nystagmus with left tonic deviation of the neck. And this was associated with this buildup of repetitive or of rhythmic spiking seen over the right posterior head region. And then this seizure progressed into a generalized tonic-clonic seizure. So the patient had a photoparoxysmal response, triggering a focal seizure from the right posterior head region, so a focal to bilateral tonic-clonic seizure. So to sum up the findings, a patient with history of seizures, of generalized tonic-clonic seizures, of myoclonus, of visual seizures, who had myoclonus, photoparoxysmal response, and generalized discharges with a bioccipital or bioccipital-parietal spike wave complexes and polyspike wave discharges, and with a slow background. So the differential might be juvenile myoclonic epilepsy. Now, what was with this diagnosis was that the patient had myoclonus, and the photosensitivity was against was the slow background, the intellectual delay, and the visual seizures. Now, another entity, which is the idiopathic photosensitive occipital lobe epilepsy. Now, what was with this diagnosis was the photosensitivity and the visual seizures. Again, what was against was the slow background, the intellectual delay, and the presence of myoclonus. And the final diagnosis which the patient had was the Lafora disease. So Lafora disease or Lafora body disease, progressive myoclonic epilepsy with the polyglucosan bodies, progressive myoclonic epilepsy with the EPM2A and EPM2B. All of those are different namings for the Lafora disease. It was first described by the Spanish scientist Gonzalo Lafora in 1911. Well, what is the pathophysiology of this disease? The pathophysiology, it's an abnormality in the synthesis of glycogen and an accumulation of abnormal glycogen molecules. So what normally happens is in the process of synthesis of a glycogen, the glucose molecules are elongated, and this is mediated by an enzyme called the glycogen synthase. And then after the elongation, there is the introduction of branching points by the glycogen branching enzymes. And then you will have the glycogen molecules, which are water-soluble molecules. And then those molecules are degraded by the glycogen phosphorylase and other glycogen debranching enzymes. Now, what happens is that when we have abnormalities in two proteins, which are the laforine and the malin proteins in patients with Lafora body, the result would be the accumulation of the abnormal glycogen, which are the Lafora bodies in different organs and tissues, mainly the CNS. So here we see this is the hippocampus in the mouse model. And we see in a mouse model with the laforine knockout, we see the accumulation of the Lafora bodies. Now, what is the clinical manifestation of the Lafora disease? They characteristically have visual seizures as the first manifestation, followed by generalized tonic-clonic seizures, absence or drop attacks. The visual seizures present as transient blindness, simple or complex visual hallucinations, and then soon after the onset of the seizures, myoclonus appears It occurs at rest and then increases with emotions, actions, photic stimulation. The myoclonus is frequent during wakefulness, especially in the early morning, and it usually ceases with sleep. Later, the patients will have rapidly progressive dementia, apraxia, and speech becomes extremely difficult, and they become ataxic, and they will become spastic, and finally they will become totally disabled, bedbound, and they die within a decade of the first symptom from status epilepticus or aspiration pneumonia. Although the Lafora body accumulate in many different tissues, such as muscles, heart, or liver, other systemic symptoms are rare. So the main symptoms are from the accumulation of Lafora body in the CNS. Now, the two main genes that are involved in this disease are the EPM2A gene and the EPM2B gene. The EPM2A is responsible for the production of the Laforine protein, and the EPM2B for the Malin protein. Both are on chromosome 6. The EEG in patients with Lafora body may be initially normal, but it rapidly deteriorates with the appearance of the first seizures. Epileptiform abnormalities are generalized or focal. They are multifocal. They predominate in the posterior cerebral regions, in the occipital and occipitoparietal head regions. Neurophysiological abnormalities are consistent with cortical myoclonus. The first features of the EEGs are usually the slowing of the backgrounds. Then later, the patients will have evidence of high amplitude spikes and polyspikes with a bioccipital predominance with photosensitivity. And then later they will have disappearance of the normal sleep architecture with diffuse slowing, and then they will have absence of REM sleep as well. So this is an example of a progression of the EEG in a patient with Lafora. So we see at the age of 17 years, there is only generalized slowing, and then we start seeing at the age of 19 years, the generalized polyspikes with a bioccipital predominance. And then we started seeing the slowing becoming more severe with the generalized polyspikes at the age of 23 years. And again, at the age of 25 years, it's status epilepticus. Now, the diagnostic procedures, we usually do skin biopsies that will show the presence of characteristic periodic acid shift positive glycogen-like intracellular inclusion bodies in the myoepithelial cells of the secretory acini of the apocrine sweat glands and in the eccrine and apocrine sweat duct cells. And this is an example of a Lafora body in the sweat glands. Also genetic testings, and in 95% of cases of Lafora disease, we will find that they will have either the EPM2A or the EPM2B gene mutation. However, a third gene may be responsible for the remaining 5%. The prognosis of Lafora disease is invariably progressive and fatal, leading to death in 5 to 10 years of clinical onset. And the slower progression has been observed in some patients who have survived after the age of 30 years. And this is a very nice graph by Professor Delgado Escueta, looking at patients with the EPM2A, and we see here that most of them, they die by the age of 20 years. However, there is a subset of patients with the EPM2B gene mutation. 25% will live beyond 30 years of age. Now, there is no curative or preventive treatment available for this disease, unfortunately. Now, the pharmacological therapy is limited to symptomatic treatment, mainly of the myoclonus. So we usually use valproate, benzos, clonazepam, and anti-myoclonic medications like levetiracetam, piracetam, and the new medication perampanel. We try to avoid medications that might worsen the myoclonus, like lamotrigine, sometimes phenytoin, carbamazepine, gabapentin, and vigabatrin. All of those might worsen the myoclonus. Also, the new anti-epileptics like the zonisamide, the topiramate, and levetiracetam might also be helpful in controlling the myoclonus. The ketogenic diet did not show any benefit in a pilot study, including 5 patients with Lafora. There were several reports in the literature on using of perampanel, which is a GABA antagonist, and it showed some very promising results. So this article by Dr. Bergminassian and Goldsmith, they reported using the perampanel in on 10 patients with genetically confirmed Lafora body. So 3 patients withdrew because of inefficacy or side effects, and 7 had major improvement in myoclonus, with group-adjusted sum score of myoclonus intensity reduced from 7 to 5. However, there was no significant improvement in disability and cognition in those patients. Another also a case reported by Professor Beydoun in a patient with Lafora disease. This patient had remarkable improvement, both in terms of myoclonus as well as the cognitive function. Also, another report from Germany on a patient who had also remarkable improvement on perampanel. Now, there is this promising initiative led by leaders in the field of Lafora disease, Professor Delgado Escueta, as well as Dr. Bergminassian and other leaders who first described the Lafora gene. Now, this initiative, we were part of it in 2015, and the aim of this initiative is to cure Lafora disease. They are trying to replicate what happened with the cystic fibrosis with the timeline for the cure. And hopefully we will get some promising results and medications in order to help those patients. I personally lost 2 patients with Lafora. One of the patients recently died, and we are hopefully waiting for any results anytime soon in order to treat those patients. So now let me go to the second case. This case is a 31-year-old right-handed female patient with history of seizures that started at the age of 12 years. She had the history of early morning myoclonic jerks that were exacerbated by sleep deprivation, and then later had generalized tonic-clonic seizures. Now, 10 years ago, she started to develop dysarthric speech and gait instability. Family noticed also that she slowly started to progress in her intellectual. So she had a slow progressive decline in intellectual ability. The parents are first cousins. She had 3 sisters with epilepsy, myoclonus, and various forms of ataxia, so strong family history. Her medications were levetiracetam, valproate, and clonazepam. On exam, she had action and task-induced myoclonus. So let me show you her EEG. So in this EEG, I'll show you an example of her myoclonus. So as you can see, she had myoclonus that was an action myoclonus. She also had the polymini myoclonus, as you can see here. Also startle myoclonus, when somebody opens the door, she would have those startle myoclonus. Now, when we look at the EEG showed that she had the slow background for her age. And during those myoclonic jerks, it was difficult to appreciate whether there were any discharges because of the artifacts generated by the muscles. Also, her interictal EEG showing those high amplitude generalized spike and polyspike wave complexes with a bifrontal amplitude predominance, and again the slow background. And those high amplitude generalized discharges were associated with myoclonic jerks. Now, the patient did not have any evidence of photoparoxysmal response. And just to go through the differential, so again, juvenile myoclonic epilepsy is on the differential, especially initially during the course of the disease with the myoclonus and the photosensitivity. So the patient had evidence of photoparoxysmal response. Now, what was against this was the slow background and action and task-induced myoclonus, as well as the intellectual delay and ataxia, which is not seen in juvenile myoclonic epilepsy. Now, the patient was found to be homozygous for CSTB gene, and the disease was the Baltic myoclonus or the Unverricht-Lundberg disease. Now, this syndrome was first described by Unverricht in 1891. And later in Sweden by Lundberg in 1903, who described the disease and traced the affected family back to the 1700s. So this is the plot of the family tree of the patients who were affected with Unverricht-Lundberg disease. As published by Lundberg. Now, the aim was to trace those patients who had genetically, who were described as genetically degenerated because of unwise marriages. And Lundberg was a scientist during the Nazi era, and they had this theory about the racial hygiene, and this was one of the projects to trace those patients. Now, the demographic data of patients with Umberich-Lundberg. In 86% of patients, myoclonic jerks appear at 9 to 13 years of age. Both sexes are equally affected. It occurs mainly in the Scandinavian countries, in Finland, Sweden, and also the Mediterranean countries and North Africa. Now, the clinical manifestations are characterized by cortical myoclonus, GTCs, and mild progressive ataxia. Patients are initially neurologically normal and may remain so for many years after the onset of the disease, when compared to the Lafora disease, when they have very rapid cognitive decline. Myoclonus and GTCs progressively worsen over 3 to 8 years, and they will have severe action and reflex myoclonus. They become most incapacitating symptom. It also takes the form of continuous shivering, like small amplitude myoclonus affecting every muscle of the body, including the tongue and the mouth, as shown in our patient. The characteristic feature is relative remission of symptoms, and this is very important. Like the patient, you will put him on the same regimen. They will have the myoclonus that you will not be able to control, and then they will have those good periods whereby they will feel very well. However, with time, with the progression of the disease, the good period they tend to shorten, and the disease severity may vary among affected individuals. So you will have some individuals with the same repeat expansions who will be severely affected by the disease, while other family members will have only mild form of the disease. Now, the CSTB gene is located on chromosome 21, and the protein is cystatin B. The EEG will show diffuse EEG background slowing with the recurrent paroxysms of spike and polyspike waves. Also, focal spikes might be seen in the central region, and photosensitivity is a prominent feature. Observations of large series in recent years have demonstrated normal to slightly slow EEG background and brief and rare epileptic paroxysms as the also the disease progresses. The background will become slower, and also the discharges will tend to disappear. Now, the disease course is inevitably progressive. The rate of deterioration, especially in the terms of walking capacity, seems to vary even within members of the same affected family. There are cases that the myoclonus is mild, and they are usually mistaken for JME. And also at the onset of the disease, most of those patients, and sometimes the patients with Lafora, are mistaken with GME. Now, generalized tonic-clonic seizures are usually controlled with treatment, even if the myoclonic jerks may become severe. Now, this study published in Neurology, they looked, it was in Italy, they looked at 59 patients with CSTB gene mutations, and they looked at what factors were poor prognostic factors. So they found that the age less than 12 years at the onset of the disease, severity of myoclonus at first assessment, if the myoclonus is very severe at first assessment, and seizure persistence more than 10 years after the onset are all poor prognostic variables. Now, the management usually, mainly we use the valproic acid with clonazepam, piracetam, levetiracetam, topiramate, and zonisamide. So the first line is usually valproate and clonazepam, and then we might use zonisamide, levetiracetam, topiramate, phenobarb. Also the third line strategies are the lamotrigine, VNS, brivaracetam, and perampanel. In this article, they looked at perampanel in 12 patients with unbridged Lundberg disease, and they found that the efficacy on GTC was, very, very good. However, on the Myoclonus, only 50% had response. In my experience, I'm following two families with unbridged Lundberg disease. Well, when we tried the perampanel, they had an initial improvement. However, later the improvement will abate, and the patient will eventually deteriorate. Also, they looked here at brivaracetam in patients with unbridged Lundberg, and in this study, the brivaracetam did not dissociate from placebo. So it was a negative study. Now, when they looked at neurostimulation in unbridged Lundberg disease, they looked at VNS, and in this report, one patient had VNS implanted, and they found that this patient improved not only in seizure control, however, and also the ataxia and cerebellar function. I had one patient who had the VNS implanted. However, unfortunately, he did not improve in terms of the ataxia and the myoclonus. So I had to stop the VNS. Another also report looking at the DBS, the deep brain stimulation in patients with progressive myoclonic epilepsy in adulthood. So they look at 5 cases, and also they found that in all patients, the reduction of myoclonic seizures was observed to range from 30 to 100% as quantified by the standardized video protocol. Here we will end the second case, and we'll start with the third case. So this is a 19-year-old right-handed male patient with history of myoclonic jerks since the age of 13 years, so since adolescence. The myoclonic jerks, they worsened with time, causing recurrent falls and trauma. He would have every 1 to 2 month period crescendo myoclonus that would evolve into a generalized tonic-clonic seizure. What was peculiar in this case, that the myoclonus, according to the family, would not disappear during sleep and would continue even during sleep. Now, 2 years prior to presentation, he became dysarthric, also a decline in the cognitive function, and this is very common in all the progressive myoclonic epilepsies. And he also had decrease in vision and instability while walking. The patient did not give any history of absence seizures. On exam, he had decreased visual acuity in both eyes. He had vertical nystagmus. His finger to nose exam showed terminal ataxia. He had hyperreflexia and normal motor and sensory exam. During examination, what was noted is that he had severe action and startle myoclonus. Now, looking at this patient's EEG and myoclonus, you can see that he had severe myoclonus involving both upper extremities. But what was peculiar in this particular case was that the myoclonus was seen involving the mouth, as you can see here. So this is very peculiar. That was not seen in the both on the previous 2 patients. And again, those myoclonus were associated with high amplitude discharges that were seen embedded in the muscle artifact seen here. Now, in this patient, interictally and during sleep, we can notice that the discharges were needle spikes, mainly in the central vertex, as you can see here. And also, when we put the video, we can see that the patient would have the myoclonus involving mainly the perioral region during those discharges. As we can see in this example. So also the EEG showed evidence of mild slowing of the background, and he didn't have any evidence of photoparoxysmal response. Now his eye exam showed the cherry red spot, and when we look at the differential for the cherry red spots, we can find that it is present in metabolic storage diseases like the Tay-Sachs, Farber, Niemann-Pick, also in other congenital developmental diseases like the Leber's congenital amaurosis, in hereditary familial diseases, in vascular, like in central retinal artery occlusion, in some of the drugs, and in CO poisoning. The patient was diagnosed as sialidosis type 1 based on high levels of sialyl oligosaccharides in the urine, which was confirmed later by genetic testing. So sialidosis are rare autosomal recessive lysosomal storage disease caused by alpha-N acetylneuraminidase or sialidase deficiency, resulting in the accumulation of sialic acid-rich macromolecular storage and urinary sialyl oligosaccharide excretion. The typical macular change found in this metabolic disorder led to the definition of the disorder as cherry red spot myoclonus. The gene is the NEU1 gene, which is present on chromosome 6, and the protein is neuroaminidase. It is classified into two forms. Now, the more severe form is the type 2. Typically, it has with it dysmorphic features, intellectual impairments, and those two are virtually absent in the type 1. Now, the type 2 is suspected early in life because of the dysmorphism, mainly the corsal facial features, the short trunk, barrel chest, and other deformities, associated also with corneal clouding, hepatomegaly, and inner ear hearing loss. Now, also the signs associated with psychomotor delay, ataxia, and generalized seizures. While myoclonic presentation may occur later during childhood or adolescence. Now, the type 1 starts between 8 and 15 years with impairment of visual acuity, like in our patient, myoclonus, and other types of generalized epileptic seizures. The cherry red spots in the macular region of the fundus appear early. The myoclonus is predominantly facial, affecting mainly the perioral muscles, and this is very peculiar to this disease. It persists in sleep and becomes progressively worse and debilitating. The cerebellar ataxia, cataracts, and color and or night blindness may develop, and visual gradually deteriorates into blindness. Also, the diagnostic procedures, the presence of cherry red spots, the detection of high levels of sialyl oligosaccharides in the urine, and lysosomal enzyme deficiency in leukocyte or cultured fibroblast, and the MRI normal in the early stages, but however, as the disease progresses, there is cerebellar pontine and cerebral atrophy. The EEG background is substantially preserved, although it may include a moderate amount of theta activity and brief paroxysms of bilateral spikes and polyspiked wave with maximum amplitude in the central EEG regions, like in our patient, combined with rare spontaneous bilateral myoclonic jerks. Photosensitivity is mild or absent. Myoclonus mainly occurs during motor activity and typically takes a pseudorhythmic course. Rhythmic EEG fast activity are sometimes visible on central and vertex regions, occasionally associated with spikes. Now, sialidosis type 2 has a poor prognosis, as already said. However, the type 1, the course of the disease may be long, and most patients have a near normal life expectancy. However, this is a progressive, there is a progressive visual impairment, and the myoclonus may be progressively debilitating, and falls induced by myoclonic seizures may be fatal. Now, the next case is a 21-year-old right-handed female patient who presented at the age of 7 years with hepatomegaly, anemia, bone abnormalities, and she was diagnosed as Gaucher's disease in 2002. She also has a brother who was diagnosed with Gaucher's disease. Now, the patient was started on enzyme replacement therapy with Cerezyme in 2003, and she was stable. She has two brothers with Gaucher's, actually. At the age of 16 years, she had her first generalized tonic-clonic seizure, and this was followed by episodes of myoclonic jerks that started to increase with time. Also had spells of staring. The patient first presented to the epilepsy clinic on 2014, and she was maintained on oxcarbazepine and valproate. Her physical exam showed prominent polymini myoclonus, action myoclonus, and terminal ataxia, as well as minimal dysarthria and hyperreflexia. And we will show the EEG now. Again, in this patient, we are looking in a longitudinal bipolar montage. As we can see, she had slow background, and she had discharges that were occipitally predominant, similar to the discharges seen in the first patient with Lafora disease. However, what was noted in this patient was that those discharges appeared when she closed her eyes, as we can see here, and they were blocked by opening the eyes. Again, when she closed the eyes, you can see that the discharges appeared. And here again, when she opened the eyes, her eyes, the discharges were blocked. So we tested whether those were eye closure induced discharges or fixation of phenomenon. So here in this part of this EEG, we are testing for the presence of fixation of phenomenon. So I asked the patient to close her eyes, and you see how the discharges are activated. She also had some delay in response time when I told her to press on the event button. And here, when she opens the eyes, you see how those discharges are blocked. We tried to test for the presence of a fixation of phenomenon by using goggles. And here we see that we asked the patient to keep her eyes open while the goggles were on. So here we removed the fixation, and as you see, the discharges appeared. However, as soon as I will remove the goggles and her eyes are opened, you will see that those discharges will disappear here. Also, the patient had a slow background. However, she didn't have any evidence of photoparoxysmal response. So Gaucher's disease is an autosomal recessive lysosomal storage disease that results from the deficiency of acid beta glucosidase or glucocerebrosidase, which leads to an accumulation of its substrate in the reticuloendothelial system, particularly in the spleen, liver, bone marrow, and lung. It was first described by Philippe Gaucher in 1882 in a patient with massive splenomegaly and leukemia. Common manifestations, the systemic, are the anemia, thrombocytopenia, splenomegaly, hepatomegaly, and skeletal pathology. And this is the pathophysiology of the disease, the accumulation of the glucosyl ceramide secondary to the glucocerebrosidase deficiency. And as we can see here in the slides, the accumulation of the glucoceramide in the different tissues. So there are three types of such disease. The type 1, which is the chronic non-neuropathic form. So those patients will have serious systemic manifestations, but they don't have any neurological findings. The type 2, which is the acute neuronopathic form. So they have extensive involvement of the central nervous system. It usually presents in the first 6 months of life, and most patients usually die before the age of 2 years. And the third type, as in our patient, so patients typically live into their third decade of life. They have oculomotor apraxia, supranuclear ophthalmoplegia, extrapyramidal features, myoclonic or generalized seizures, cerebellar ataxia, and developmental delay. They also have horizontal supranuclear palsy, is often one of the first neurological signs. Some patients present with moderate systemic involvement with horizontal ophthalmoplegia as the only neurological symptoms. However, others who have more severe forms, including progressive myoclonus, cerebellar ataxia, spasticity, and dementia. The neurological signs may occur several years after the visceral manifestation, so they will be initially diagnosed as the type 1, and then several years later, like in our patient, they will have the myoclonus and the seizures. Also, they looked at the long-term follow-up of EEG and clinical findings of a case with Gaucher. I believe this was in Turkey. And as you can see here in those patients, they had similar findings to our patients. So EEG revealed generalized non-rhythmic paroxysmal rapid 6 to 8 hertz with marked occipital predominance, increased biphotic stimulation, and normal background activity. The gene encoding for the glucocerebrosidase is in chromosome 1 with more than 200 different mutations. Currently, target therapy is possible only for minority of such patients. Enzyme replacement therapy is used to treat patients who have non-neuronopathic form, and it will not affect the neuronopathic Gauchers because it will not cross the blood-brain barrier. There is also the substrate reduction therapies, such as the miglostat, which is an inhibitor of glucosyl ceramide synthesis. And this form of treatment is able to cross the blood-brain barrier. Nevertheless, in open label trials, it did not show any significant benefit combination when combined with the enzyme replacement therapy. So what happened to our patient? Patient was started on perampanel at a dose that was increased to 6 to 8 milligrams. However, the myoclonus was not controlled. She was started on the aliglostat 1 year ago, and also no major effect on the myoclonus. One of the recent videos that was sent showing how debilitating is her myoclonus. Here she was having near continuous myoclonus. It was a myoclonic status. So I realized that I'm way past my time. So I had one more case with neuronal ceroid lipofuscinosis, which I'll omit, and I'll go directly to the conclusion. So progressive myoclonic epilepsies comprise a group of rare heterogeneous genetic, mainly autosomal recessive disorders. They are characterized by cortical myoclonus, other types of epileptic seizures, and progressive neurocognitive impairment. Major advances are being made in the treatment of Lafora disease with phase 1 and 2 trials. Treatment of other diseases is still somehow lagging behind. I also would like to correct, I mentioned earlier that perampanel is a GABA antagonist, which I meant to AMPA antagonist. So perampanel is an AMPA antagonist. Thank you very much.
Thank you, Maher.
Thank you. Thank you very much.
I have
Dr. Adel.
some problem in the laptop. I try to be connected through my phone. Okay. Thank you, Maher. Again, it was excellent presentation. I know that the progressive myoclonic epilepsy, it's many other forms, but you have shown the 4 cases. That's excellent. I have some question. What about, I know in 2016, it was a grant about the metformin therapy in Lafora body. Do you have any experience about it?
Yeah, actually, this was proved in a lab by Ceratosa in Spain, who's also who was one of the pioneers who described the gene for the Lafora.
21 yours.
And you know, it showed in the rat models that it will reverse the accumulation of the Lafora body. However, when it was used in patients, it didn't show much improvement. I had some patients, 2 patients from the same family. Sorry, it was 1 patient that I used the glucophage or the metformin on, and I didn't see any clinical improvement. And then later, the patient passed away, unfortunately.
Okay, thank you. The question, did you have in Kuwait, we have the Palestinian community. Did you have any experience about the Palestinian community with the Lafora body?
No,
because
actually,
here in Palestine, yes.
Yes. I know that Dr. Professor Delgado Escueta is following some families in Palestine. He mentioned that. You know, fortunately for the for the Palestinians living here, that I didn't the families that I'm following. You know, I had 1 patient who was she was Kuwaiti, and another, but she didn't have neither the EPM2A nor the EPM2B. She had a SCARB gene mutation. And the other family are the Bidun. They are Bidun. They have the EPM2A gene mutation. 1 patient already passed away, unfortunately. And I have her sister I'm still following. And the father and mother are heterozygous for the mutation.
Okay,
but
thank
I
you.
don't have any Palestinian cases.
Okay, thank you. If there is any question, I didn't see. Okay. I have just a minute. How often the MERRF syndrome is associated with lipomas?
Well, you know, it's a rare disorder. I don't have any cases that I'm following. I don't know the answer, unfortunately. So how many cases with MRF are associated with lipomas, or how often? I don't have the answer for that. And
Another question from Dr. Ghalib. Is there a problem in the nerve with the valproate as treatment option?
You know, MRF is a mitochondrial disease, and in general, in pediatrics, you know, they try to avoid valproate in patients who have mitochondrial diseases. So I think they try to avoid it when it is diagnosed, especially with the MRF. They try to avoid it.
And does WES cover the gene of BLD given it included repair?
Yes, I think it does include it. So when they do the WES, it will include the. But what is the gene? The Unverich-Lundberg, the CSTB gene. Yeah, it should include it, I think.
Are we able to help Myoclonus and other seizure type in Gaucher by first-line drug used for Myoclonic epilepsy, like clonazepam, levetiracetam, and Debacin?
Yes, you know what is common for all the progressive myoclonic epilepsies is, you know, that all the medications that help in the myoclonus and in the GTC are used. So you can extrapolate this to most of those cases. So mainly the first, you know, the first thing that you will use are the valproate and the clonazepam, and then you will start adding eventually the levetiracetam, the clobazam. Also, you will add later the topiramate, then the perampanel. You know, so but most of them, the myoclonus, they will deteriorate with time. So the Unverich-Lundberg disease is a slowly progressive disease. So you might help them at first. However, you will see that most of the cases, like in 3, 4, 5 years, they will be on a combination of 5 anti-epileptic medications. Now, what's, you know, the cornerstone in management are the valproate and the benzos. So those are always on board. And then you will try using other combinations, like the perampanel in patients, as in reported as in I showed in other cases, like of Lafora. There were some data that showed that it helps. In my patients, unfortunately, it didn't help much. But on other patients who have Unverich-Lundberg, I put them on perampanel. The family, most of them, you know, I have 4 sisters. All of them are on perampanel, valproate, and benzos. Zonisamide also is helpful in some of those cases. In the Gaucher case, you know, also she was on 4 or 5 anti-epileptic medications. However, she still have the myoclonus. So I was able to control the GTCs, but the myoclonus and the deterioration in the cerebellar function is still there.
Okay, you mean that the next strategy for the therapeutic in the future, it's still anti-epileptic drug or something else, or enzyme replacement?
You know, do you mean for Gauchers or for all the progressive?
For
all. Now for the Lafora, we are just waiting for the new trial, for the trials that are ongoing, actually phase 3 trials. Now what is good in Lafora is that they have this initiative that they are doing, and they are integrating the drug companies with the scientists, with the labs, with everybody. So, and now they managed to have a knockout. A few years ago, they have a knockout mouse with the model of Lafora, and they are making lots of progress in this particular field. Now I have personal connection with Professor Delgado, and we follow patients together. And there is a company called Ionis. They are working also on a trial of a medication that might be helpful for those patients within the next year or so. Now for the Umberich-Lundberg, there are not much trials, on other medications, because maybe it's less progressive than the Lafora. But with time, I have you see lots of phenotypes. So I have a family of 4 sisters. The elder now is wheelchair bound. With the younger seeing the elder sister, so this will affect a lot their psychiatric, their mentality, and looking at what might happen to them in the future. And also for the Gauchers, they looked at the medications that might cross the blood-brain barrier. However, it didn't show in the clinical settings any improvements. So treatment is not, so treatment is not the anti-seizure or the anti-seizure medications. We should tackle the main problem in order to reverse, because you might temporarily control the myoclonus or the seizure. However, all the intellectual decline, as well as the cerebellar dysfunction will continue.
Okay. Thank you, Maher. Thank you, Mesraoua.
Thank you.
Thank you for all the audience and who participate.
Thank you very
Hope to
much.
see you again.
Thank
And Happy New Year.
Thank you.
Inshallah, بدون
Thank you.
corona.
Thank you.
Thank you.
Thank you.
مع السلامة.